Hello, good evening or good afternoon, everybody. My name is Martin Kuhlmann. I'm joining in from Berlin, Germany. I'm one of the former lab directors at RI, so closely connected to Renal Research Institute. It's always been a pleasure joining the conference. I'm very happy to introduce three speakers, and I'm sure you all watched each presentation. So let me say hi to Sumit Mohan. He's on the picture here now. Dr. Mohan is an associate professor of medicine and epidemiology at Columbia University, New York, and the director of clinical research for the division of nephrology. Next is Dr. Husain. Dr. Husain is the assistant professor of medicine in the division of nephrology at Columbia University Medical Center in New York. And third, last but not least, I'd like to introduce Joel Topf, who just gave a presentation, I think, right before this question and answer session. He's working in Detroit at St. Clair Nephrology, and he's involved in medical education since before graduating medical school, so an old teacher, Joel. And so he's just been presenting on FOA Med in the pandemic. So let me start discussing the presentations, and I'd like to start with Dr. Mohan. You presented on the barriers to transplantation during the COVID. Your presentation, I think, was in December, right? Because we were all preparing for the RA conference in January. So right. Can you maybe just comment on what changed in the barriers? Because I think you didn't mention any vaccination issues at that time. So what was the major change since January?
So I think so. You're right. We recorded our talks months ago, and with everything COVID, things are changing rapidly. With vaccinations, I think the access to transplantation in terms of concerns around aggressive immunosuppression immediately post-transplant is reduced, and so I think the hesitation to transplant our older patients has certainly decreased. We're now encouraging patients to get vaccinated before transplant. In part because I think it keeps them safe perioperatively, but also because we now have evidence that the vaccines don't work well post-transplant.
But that evidence, do we have functional data? Have we actually tracked people that have gotten vaccines? I know they're not producing antibodies. Do we know that also translates into lack of protection?
So that's a very good question. So Ali should probably answer this, but we now have a series of individuals who've gotten vaccinated and have gotten infected subsequently, with transplants.
Yeah. There was a series published in HAT today of 7 cases of kidney transplant recipients who had gotten COVID after vaccination. At our own center, we've had actually over a dozen cases of patients who've been vaccinated who are kidney transplant recipients who've gotten COVID-19. And including severe disease requiring hospitalization and ICU care and even death. So not only does it appear to not confer protection against infection in general, but also not necessarily confer protection against severe disease.
Do we have a sense of the denominator for those 12?
Yeah, so that represents just under 2% of our vaccinated people. But that's in a very short duration of time, right? So that's like after only a couple of months of the vaccination effort. So pretty fast.
Yeah.
Okay, so that's the impact of vaccination. So you also discussed the role of the nephrologists in the United States, Sumit, and I think you recommended that, or you mentioned that centers should refer their patients to the centers with shortest wait time, and as you mentioned, so there are big differences in waiting time on the list. And I was wondering, do the centers with the shortest wait time at the same time have the highest racial disparities?
So that's a very good question. So the challenge we have in the US is that there's an enormous amount of variation in the probability of transplants once you get on the wait list. What we don't know is what is the level of access to the wait list. So we have no pre-transplant data nationally in terms of who's being referred, what among the people who are being referred, what proportion of people get waitlisted, and among waitlisted, who's getting transplanted. There is some data to suggest that some racial minorities get passed over more often than not for organs. And when patients are trying to pick centers, I think it's been a large black box, right? So patients want to go to those centers which give them the highest chance of probability, the shortest time to transplant. And that information is not easily or publicly available. That's one. And we now have extensive data that shows that socioeconomic status and racial minorities, are disadvantaged in terms of getting through the complex evaluation process in a timely manner, and that again impacts their ability to get to the wait list and get transplanted. So it's a significant problem, and one that I think particularly over the last year, with all of the attention around structural racism in healthcare, has taken on a new sense of urgency.
Okay, thank you very much. So let me turn to Dr. Husain again. You discussed, organ donation, and also before vaccination was available. So what are your recommendations now? Do you recommend vaccination, COVID vaccination for organ donors before donation?
So I think that, I largely spoke about the deceased donor supply, but obviously the living donor supply is impacted both. So maybe I can answer those a little separately.
Yes.
I think regarding the impact on the deceased donor kidney supply, hopefully, obviously we don't make any medical decisions about vaccination for donors after they have already deceased. But I think hopefully the kind of widespread availability of vaccination will allow us to expand the donor pool by kind of reducing the risk of kind of COVID-19 infection in the donor that could be potentially transmitted to their intended recipient. Regarding living donors, I mean, I think there's no evidence to support that the act of donation would impact immunoreactivity to vaccination. There's one small series recently published, now blanking where it was from, but basically showing that kind of outcomes for COVID among living donors are pretty close to the general population. I think we would expect that outcomes for COVID-19 vaccination in living donors should be similar to the general population as well. So I think obviously what would be good would be for them to get vaccinated before entering the healthcare setting for an admission in a place where there'll be other sick people. But I think that there's no specific kind of vaccination rules that need to be implemented among living donors.
Okay. So we are not aware that any surgery or any, donating a kidney kind of changes your risk for COVID, right? And for the severity of disease.
That's correct. Yeah, it's kind of small scale case series, but that's correct. And that's probably because we're only accepting the healthiest of the healthy people to be living donors. So as expected, their outcomes, even if they get infected, are excellent. Of course, we wouldn't want them to get any exposure if at all possible.
Can you comment on what changed since January, since your presentation?
Yeah, I think the biggest thing is that, so if you look back at the US national kind of deceased donor kidney utilization, last spring and summer, there's a huge drop off. I think, and that's some of the stuff I presented, in the kind of procurement, or I guess recovery is what we say now, and utilization of kidneys. And kind of that non-recovery and discard was largely attributable to kind of lack of resources to actually continue to perform transplant, which is kind of semi-elective procedure, and also an inability to find recipients kind of who would be safe to transplant during this time, and kind of an unwillingness to immunosuppress them. I think as our comfort with kind of treatments for COVID-19 has gotten better, as our kind of just general fear of this brand new disease has gotten better, kind of transplant rates have returned to similar to what they were before. I think a big thing, though, that Sumit likes to talk about, maybe he commented on this, is that kind of we were at a deceased donor kidney transplant rate kind of that we were at before. There was a big drop off during the peak of the pandemic, and then kind of we returned to the rate that we were at before, but haven't exceeded that. So now there's still this big donut hole in the middle that's never been filled. And the question is, does that represent a huge swath of patients who kind of have permanent missed opportunities for transplant? I don't know. What do you think, Sumit?
Right. No, I agree. I think that's a huge problem. So if you look at USRDS data, right, as you go through the pandemic in the early part of 2020 and into the summer, there's a big drop off in the number of people who started dialysis, right, and we don't know what happened to that, and it's not like those people have subsequently started dialysis later. The rates haven't picked up, and almost identical to that is a big drop off in terms of people who are waitlisted, and that the additions to the waitlist have dropped, and they have picked up again, but they've never exceeded where we were at the end of 2019, suggesting that we're going to start to experience this continuing shrinking of the waitlist, potentially inappropriately. The shrinking was already in place because of the way the kidney allocation system allocates time, but I think COVID has done has created real barriers to getting waitlisted from that perspective. And perhaps what's most troubling about all of this is that we just published some data that showed that as you get further out from the time you start dialysis, the probability of you actually getting on the wait list starts to decrease. Mm-hmm. Like fewer and fewer patients get on the wait list late after, many years after they've been on dialysis. So having this gap, is I think the ramifications of what COVID has done to access to care, we're probably going to continue to see for months and years to come.
Okay. And I think similarly, we'll probably see that really translates to more disparities in who's getting listed and transplanted, because we know, at least outcomes wise, Jesse Schulz recently published this data that on the candidates who are on the wait list, those who kind of had to get delisted due to death from COVID-19 tended to be people who were kind of poor, more likely to be socioeconomically deprived, more likely to be minority race. So I think that that in addition to impacting their outcomes on the wait list, it also will impact, we'll later find their access to the wait list.
Okay, so Joel, I'm turning to you now. So there are some questions on the chat for you. I think you already read these questions. So what are your thoughts on how to address vaccination hesitancy through social media, and how can we combat the rampant misinformation around COVID-19 on social media?
Yeah, well, honestly, I think confronting misinformation head on and talking to people through social media that are spreading that misinformation, and emphasizing and providing evidence-based and reasoned approaches. In the end, the solution to pollution is dilution. That if we have more and more doctors providing good and accurate information, that's going to be the best offense against this kind of misinformation. You need to, one of the strategies that people that do with misinformation is they flood the zone with as many different identities, spreading the information and reinforcing the information. And this is the strategy that people purveying the truth can also use, right? If we have a lot of people that are talking reasoned, evidence-based information, spreading that's probably our best counter. And then, vaccine hesitancy, like we've got a good model for that. Like Israel is cracking 80% vaccination rate in their country, and they had a lot of misinformation, and they had very isolated subpopulations. The ultra-Orthodox that live in Israel had a very high degree of vaccine hesitancy, and the government took this on head on, countered myths, and did a big public information campaign to counter vaccine myths. And whether that was through traditional mass media or through social media, I'm actually not aware. I don't know what they specifically did through social media, but that's a real powerful aspect. I think in our society, we have a lot of division, a very fractured environment. And I think that a wholesale movement by the government may not be very receptive for the people that are already vaccine hesitant. I think they tend to be people that already mistrust government information. But I think that's a group of people that do listen to their doctors. I know that I've had patients come to my clinic that have been vaccine hesitant, but they've been very receptive to me telling my story and expressing information. And, I believe that I've been able to turn some people, but that's, again, that is not so much a social media. That's because I already have a long-standing relationship with these people, and I'm able to talk to them, and they already trust me. And I think that may be the most effective way that we could counter vaccine hesitancy.
Okay, in social media, I think as you are using social media, it's doctors for doctors, right? Scientists for scientists mainly. What about the for the lay people and for the public?
Yeah, no, but I think you're right that most of my work on social media, at least my intentional work, is doctors to doctors. But I have, the number of followers I have far exceeds what I think are doctors. I think that I have a lot of lay people that are following me, again, I'm not sure that the social media approach is the best approach there, right? I think that this is going to be a ground game that we do one by one with doctors using their personal relationships, though that may not be the case if people that are true celebrities, right? I mean, I think, in the end, I think President Trump's biggest miss was his opportunity to own the vaccine as part of his legacy. And instead of taking the vaccine in secret, as on the last few days of his presidency, if he had done that in public and then gone barnstorming across the red states that he won in the election, there would be a lot less vaccine hesitancy among conservative voters. And I think it would have really changed President Trump's legacy if he had done that. I think it's kind of shameful that he did not.
Yeah,
and not only shameful. I mean, he's going to. Literally, it's blood on his hands. It's an opportunity that he missed.
Any comments from Sumit or Syed?
Well, Joel, I'm wondering, do you think there's a role for policing? Not policing, so might not be the right word, but like moderating posts and companies pulling down misinformation, or do you think it's a better approach to just overwhelm misinformation with correct information?
No, I think absolutely. I think what we have seen is that a lot of misinformation ends up being sourced from a few target places. The question always is what is truth? And there's some stuff that is obvious misinformation, and there's other stuff that's a little bit more difficult to understand. And one of the great advantages of social media is its ability for everybody to speak. And I'm a little nervous about introducing filters there. I'm not sure how much I trust the management at Facebook to determine what is right and what is wrong. All over the world, right? And I think I think oftentimes truth is more nuanced than we'd like to think. That we all have our own personal biases. And it feels reassuring to say that we would like some of this misinformation to be taken down, but I think that can be problematic also.
So bringing these several topics together now, transplantation and COVID and social media, transplant rates is still an issue, as we discussed before. So how can we use social media and maybe your ideas to increase transplantation rate or to get people more informed about? Is there any ideas about that?
Well, I mean, we've seen many examples of people using social media to try to find living donors, and there's a success there. And the group at Johns Hopkins have actually done some studies to show this and created an app that allows patients to craft a story to post to social media, right? Essentially, the app asks them questions, puts together a compelling story, and then posts that to social media, and they've had some successes there. And I think that again, one of the big problems in getting living donors is people are reluctant to ask. And if we can normalize people asking, we may be able to increase living donor rates. I'm sure, I'd love to hear your experience. Have you seen that at your centers, people finding donors through social media?
Yeah, no, absolutely. I think that's a it's an important resource, and people have certainly engaged. I think, the fact that there have been recent posts on social media where people who have donated have kind of documented their experience as donors. I think all of that works, right? I think social media in some ways is a real opportunity for us to educate patients and individuals about not just transplant, right? I think we have to do a better job of doing outreach around what kidney disease is, how prevalent it is. The fact that much of it is preventable if it is early on, or at least you could slow down progression of disease. I think it's a missed opportunity, and a lot of our educational efforts, I think, have to pivot a little bit to kind of account for the new way that people acquire information and the way people communicate. I still think I think we haven't done a good enough job as a community. I know Joel and others have kind of leading the way, but I think there's a lot more we could and should be doing.
I think that so some people, I think this came out of the Hopkins group, that, they published it. They had some concern that encouraging people to use social media might kind of increase disparities in transplant because, maybe younger, more savvy patients would have increased access to transplant. But I think that's really a mistake to think that way, because we need to remember that anytime people get transplanted, that frees up more organs for others, right? Especially people who would otherwise be waiting for a deceased donor organ. So I think that, not to disagree with them, I think that that's like a completely misguided thought. Like if some people can find living donors that would otherwise not be donating, great. Them donating and those recipients getting transplants kind of gets people off the list. And not only that, but it gets them off the list with a living donor organ that will last a long time, that will decrease their likelihood of needing retransplant. So like, I think it should be full speed ahead. And we've seen this, I've evaluated donors sometimes who say, we say, what's your relationship to the recipient? And they say, oh, I don't know them, but like my boyfriend's best friend, his girlfriend posted like, oh, I need a kidney. And then I saw that and I met her one time, or I never even met her. And, something I always thought about doing. And it's like, great, like that person otherwise would never walk into a random center and say like, oh, I want to donate. But just that thread of a connection kind of allows them to identify someone who they could potentially donate to. And that's great for the list and for all patients kind of below them on the list as well.
Yeah, I think it's a good idea. Do you have any experience of your own at your center using social media in that regard?
So I encourage every one of the kidney transplant candidate patients who I evaluate, I encourage all of them, they don't have a living donor, if they're comfortable, they should post their story on social media. And actually, for those nephrologists who are listening, UNOS and I think the American Association of Kidney Patients, I think they do too, but they actually have scripts online that you can post. I think it's a very hard thing to ask people, and it's kind of awkward sometimes. So they have scripts that you can copy and just say, they say something like, many of you might have known that I've been struggling with kidney disease for a while. I'm looking for, my doctor told me that a kidney transplant is the best treatment. And I haven't been a donor yet, right? It's a very simple thing to post. I don't think the success rate is astronomically high, but even if the success rate is, let's say 5%, right? That's such a low cost intervention that if 5% of our candidates who'd otherwise have no living donor, if they got transplanted, that would make a huge difference.
Okay, very, very good. So maybe a last round of questions. What do you think will be the biggest change after this COVID pandemic? Let's assume that the pandemic may end. I don't even want to say end. It may end, by some time. What will be the biggest change in transplant medicine, in kidney transplant?
So I think the biggest change across healthcare, not just transplant, is going to be telemedicine, right? I think we have recognized that the in-person visit may have been a little overrated. We're able to do a lot of things over a telemedicine visit that makes it convenient for the patient. They don't have to take an entire day off. They don't have to travel to you and sit in your waiting room. We may actually run clinic appointments on time because that someone else logged in, right? So I think it has forced us to look at technology in a different way. And it'll be interesting to see what that morphs into, right? It's right now just Zoom and kind of a video feed. I think it will change how we interact with our patients, what we value, what impact it has on our physical exam, how we do labs, how we share data across systems. I think a lot of that is going to change.
Yeah, I have the same observation. We do telemedicine and or phone calls, whatever is available, and it changes. You can see more patients at a time somehow, or during a day, and without losing a lot. I think it's some time after time you have to see them personally. I think. What is your experience in that? What is how can you arrange telemedicine and combine it with in-person visits?
Yeah, I think you would want to combine them, right? So we have in transplant, at least we have kind of two dichotomous say a patient population. You have the early post-transplant individuals who still have a wound, still have staples in place, kind of need close follow-up and need a visual exam. I think those individuals continue to benefit from an in-person visit. And And then there are those people who are kind of the long-term well baby visits that you could do with telemedicine. And then when you have a problem, the creatinine's up, they're complaining of shortness of breath, and therefore it is actually valuable to push down and see how much edema they have. Do they have crackles? You're going to have to bring them in. I don't think in-person visits are ever going to go away, but there's going to be a real place for telemedicine.
Yeah. What's your thought, Joel, about what will be the biggest change? Any other idea about telemedicine?
Well, okay, other ideas. So, I think medical education has indelibly been changed. Like everybody was reluctant to do these type of remote meetings before, and we've normalized them. And I'm as excited as anybody else about getting back to real social meetings. But the ability to do these Zoom meetings and the acceptance of them is going to be a game changer. For example, we had a noon conference for our fellows, and we have a small fellowship program. We had 3 or 4 fellows, but we just piggybacked on Indiana University's lecture with Sharon Moe on calcium phosphorus. So instead of me trying to, do my best review of calcium phosphorus PTH metabolism, I had the world's expert who has done a lot of the fundamental research come in and give us a Zoom lecture. My fellows were, they were dazzled by that. And this is something, and it wasn't like a special grand rounds where we had to fly around. It was just our routine noon conference. And I think that's a model that is easily reproduced and going to be do more and more. And I think this type of thing is going to bring expert education to more and more places and a lot more corners. And I think it's great, right? We're delivering on this promise of technology that we've had the technology for a long time, but we had just kind of cultural reluctance. And this pandemic has erased that reluctance.
Absolutely agree. Syed, what's your take on that?
I think that from a patient care perspective, the biggest thing it'll do is it'll make it easier to help combat some of these disparities we talk about in access to care. So, a good example is that there's a strong relationship between geographic distance from a transplant center and access to transplant. So just being able to get some care or at least evaluation process over the internet kind of will certainly decrease those disparities. There's people who, can't get to appointments because they have to go to work or because they're on dialysis or something like that. So, we've done evaluations for patients while they sit on dialysis, they sit on the machine, they're on their phone, and they get their intake, and at least they can get their workup started, get them through the system as quickly as possible to get them towards transplant. I think that I agree with Joel and Sumit that that the more telehealth, the better. I think patients like it better too, in my experience.
I think there's one last question. We only have a couple of seconds, maybe a minute left. So that's maybe to Sumit, do you foresee an increase in point-of-care testing, pervasive sensing devices, because patients are reluctant to go to hospitals in these days? I think there are lots of startups trying to develop things.
No, absolutely. I think, the idea, the world of technology around miniaturizing devices, point of care, being able to do things at home, with the Kidney X model, trying to build an artificial kidney, I think the technology in kidney disease broadly is going to really expand. And I think home testing is going to become part of telemedicine, right? Yeah. It is going to be that function. It's not just a blood pressure device anymore. It's going to be lots more.
Yeah. Well, so I think this is to conclude our discussion. I really enjoyed it. Thank you, Sumit Mohan from New York, Syed Husain from New York, Columbia University, and Joel Topf. Thank you very much from St. Clair. It was really a pleasure to watch your presentations, to listen to you, to have this discussion. And as Joel just mentioned, I think this is a new way of exchanging knowledge and get a feeling on nephrology. So we will now. Please, everybody, hold on to this session, because now we will be able to listen into the closing remarks from the organizer of this RI meeting, Dr. Peter Kotanko, who will give us his take on RI meeting, and will probably invite you to the next year's RI meeting. Let's see whether it will be in person or a digital meeting again. I think we can live with both at the moment, right?
I hope you have enjoyed the 3 days of the conference and benefited from the new on-demand library. And we would like to thank all of you who submitted abstracts for this program. As we conclude, I would like to acknowledge the best abstracts that were submitted this year. We thank everyone for your time, attention, and participation. We appreciate that you took the time to make this conference a priority. We hope that this forum continues to provide you with the most current and cutting-edge scientific insights and developments in nephrology, vis-à-vis the shared knowledge from industry thought leaders worldwide. We also hope you were able to provide you with the opportunity to develop online interactions that foster long-term relationships and potential collaborations with industry thought leaders, medical professionals, researchers, and scholars. We look forward to welcoming you again in 2022 at the Renal Research Institute's 24th International Conference on Dialysis, Advances in Kidney Disease. Thank you again and see you in 2022.